Imagine you're, say, a 17-year-old high school student. Let's call her Maha.
Yeah.
She walks into a clinic, and she's really concerned about this persistent acne on her face. Started maybe a year ago, just on her forehead, but now, well, now it's everywhere on her face. And she's noticing it's affecting her social life. She's withdrawing a bit, feeling down about herself. It reminds her of what her own mom went through as a teenager.
Yeah, that's unfortunately a very common story. It runs deeper than just skin.
Exactly.
Yeah.
This isn't just a few spots. It's a condition that can really, impact someone's life profoundly. So today, we're doing a deep dive into acne vulgaris.
Right.
It's way more complex than people might think. We're going to journey into the tiny structures of our skin, look at the sort of hidden battles with bacteria, and explore the personalized ways we need to treat it. Our mission here is to take stories like Maha's and the questions you might have and really pull out the key insights from the research. We want to give you a shortcut to being genuinely well-informed about acne, what it is, why it happens, and some of the surprising details about treatment.
Sounds good. Where should we start?
Okay, let's unpack the basics first. Acne vulgaris. It's primarily a disease of something called the pilosebaceous unit.
Right, the pilosebaceous unit. That sounds a bit technical, maybe?
It does, but think about goosebumps.
Yeah.
Ever had goosebumps? You've actually seen part of this unit in action.
Interesting connection.
So visualize your skin. You've got the top layer, the epidermis, the dermis below, and then the fat layer. Now, each tiny hair on your body comes with a couple of key partners.
Okay.
First, there's the sebaceous gland. This little gland makes an oily stuff called sebum.
Sebum, yeah. Keeps the skin moisturized.
Right, and it helps the hair slide out smoothly. Then there's the erector pili muscle, tiny muscle attached to the hair follicle. That's one that pulls the hair upright when you're cold or scared, gives you goosebumps.
Literally makes your hair stand on end.
Exactly. So those two things, the sebaceous gland and the hair follicle, that's your pilosebaceous unit. This tiny little factory is where the whole acne story really begins.
It's ground zero for acne development.
Precisely. Now, our skin isn't sterile, right? It's actually home to a lot of bacteria, mostly good guys.
A whole ecosystem, really, like Staphylococcus epidermidis and another one called Cutibacterium acnes. You might know it by its old name, Propionibacterium acnes.
Right, C. acnes. And these are usually harmless.
Yeah, usually. They're commensal. They just live there peacefully, contribute to skin health even. It's not about getting rid of all the bacteria. It's about balance.
Okay, so it's about balance. What happens when things get out of balance? What does acne actually look like?
Well, it varies a lot. From mild to really severe, the basic building blocks are called comedones.
Comedones. Those are the initial blockages.
Exactly. They show up as either whiteheads, which are closed comedones where the pore is totally blocked, trapping sebum underneath, little white bumps.
Okay.
Or blackheads. Those are open comedones. The pore opening is exposed to air, and the trapped sebum mixture oxidizes and turns dark.
Ah, so it's not actually dirt in a blackhead.
Not usually, no. It's mostly oxidized oil and skin cells. Common misconception.
Good to know. So comedones are the start. What happens next?
Well, if inflammation kicks in, things progress. You might get papules.
Those small, red, raised bumps.
That's them. And if those papules fill with pus, they become pustules. Sometimes they burst and crust over.
Okay, papules, pustules, getting more inflamed.
Then you can get deeper, larger, more painful lesions called nodules. And even bigger, pus-filled ones, often deep down, are cysts.
Nodules and cysts sound pretty serious.
They are. And there's a very severe form called acne conglobata where you get interconnecting nodules and cysts. And unfortunately, especially with these more severe forms or even moderate acne, if it's not treated well, you can end up with scarring.
Scarring. And those dark spots, too.
Right. Post-inflammatory hyperpigmentation, or PIH. Those spots can linger for a long time after the active acne is gone.
And Maha's was on her face, but acne can show up elsewhere, too.
Oh, yeah. Face is most common, but also the upper chest, upper back, even the upper arms and shoulders sometimes. Basically areas with a lot of those pilosebaceous unit.
Got it. So who actually gets acne, and why them?
Well, connecting this to the bigger picture, acne vulgaris is surprisingly common, affects roughly maybe 20%, a bit over 20% of the population overall.
1 in 5 people, roughly.
Wow. And it's most common during adolescence. Think ages 12 to 25. The peak is usually between 16 and 24 years old, about 28% prevalence then.
So it really is the disease of adolescence, as they say.
It often is, yeah. Usually starts to clear up by age 30. They're not always. Some people get adult onset acne, or it just persists. Interestingly, it seems slightly more common in females overall than males.
So the big question,
Ooh.
Why? What's actually causing it? You said it's complex.
It is. It's polygenic, many genes involved, and multifactorial, many factors contribute. But the core insight, really, is that it's usually this perfect storm of four main things happening in that pilosebaceous unit.
Okay, 4 key factors. What are they?
First, sebaceous gland hyperplasia and excess sebum. Basically, during puberty, those androgen hormones surge.
Hormones. Right.
Yeah, and they tell the sebaceous glands to get bigger, that's hypoplasia, and pump out way more sebum. Skin gets oilier.
Okay, more oil. Factor 1.
Second, abnormal follicular differentiation. Fancy term, but it just means the skin cells lining the hair follicle don't shed properly. They shed abnormally and clump together. Hyperkeratinization.
So they stick together.
Exactly. They form a plug, blocking the opening of the follicle, traps all that extra sebum inside.
Got it. Blockage. Factor 2. What's 3?
Third is Cutibacterium acnes colonization. Remember that bacteria we mentioned? When the pore gets blocked, it creates this low oxygen environment inside.
Perfect for C. acnes.
Perfect. So the bacteria multiply rapidly, they overgrow, and then they produce an enzyme called lipase.
Lipase, like lipid, fat.
Precisely. Lipase breaks down the triglycerides in the trapped sebum into something called free fatty acids. And these are irritating.
Irritating to the skin lining.
Very. Which brings us to number 4, inflammation and immune response. Those irritating free fatty acids trigger your body's immune system.
Ah, the red alert.
Exactly.
Yeah.
The immune system sends inflammatory cells, and you get the redness, the swelling, the heat, the pain, all the classic signs of inflammation associated with those angry-looking pimples.
Wow. So it's a chain reaction. Hormones, more oil, blocked pore,
Yeah.
bacteria, overgrowth, irritation, inflammation.
Oh, that's a great summary of the core process. It really takes all 4 happening together.
So beyond those core 4, what else can kind of nudge things along or make acne worse?
Yeah.
Risk factors.
Absolutely. There are quite a few. We can think about external factors first. Things like climate, hot, humid weather, more sweat, more oil, potentially more clogging.
Makes sense.
Certain drugs can trigger or worsen acne. Anabolic steroids are a big one. Also, some birth control pills, particularly the progestin-only mini pills or certain injections, systemic or even strong topical corticosteroids, some anticonvulsants like phenytoin, lithium-2.
So acne pops up after starting a new medication.
Definitely something to consider. Sometimes they call that an acneiform eruption if a drug is the main cause.
Okay. What about diet? That's always debated.
It is, and the evidence is mixed, but for some susceptible people, yes, diet might play a role. High glycemic foods, things that spike your blood sugar quickly, and maybe dairy products seem to be potential triggers or aggravators for some individuals, but not for everyone.
Is this personal?
Very much so. Then there are cosmetics. Using poor quality makeup or skincare products that are comedogenic, meaning they tend to clog pores that can directly contribute.
Check those labels.
Definitely. And, surprisingly, while overwashing is bad, really poor hygiene can also make things worse by not removing surface oil and dirt properly.
Okay, so external factors. What about internal things?
Big one is hormones. We mentioned puberty, but conditions causing excess androgens later in life, like polycystic ovarian syndrome, PCOS, or a rarer condition called congenital adrenal hyperplasia, CAH, can be significant drivers of acne, especially in women.
PCOS often shows up as jawline acne, right?
It often does, yes. That pattern can be a clue. Then there's heredity. Genetics play a strong role. If your mom or your grandma had bad acne, particularly as a teen, your risk is higher. Twin studies really confirm this.
Runs in the family.
It often does. And finally, even the environment beyond climate, things like air pollutants, maybe even UV radiation, might contribute to pore blockage in some way.
That's quite a list. Seems like almost anything can potentially influence it for someone who's susceptible.
It really highlights the multifactorial aspect, lots of potential inputs.
So you mentioned the misconception about hygiene. What's another common one you hear about what makes acne worse?
Probably the idea that eating greasy food directly causes greasy skin and pimples. The old pizza face myth.
Ah, yeah, I remember hearing that.
While a very high glycemic diet might have an influence for some, as we said, the specific fats you eat don't directly translate into pore clogging sebum in that simple way. It's more about the overall dietary pattern and hormonal responses.
Good to clear that up. Okay, so we know what it is, what causes it, what makes it worse. Now, how do doctors figure out how bad it is? Classification seems important for treatment.
Absolutely crucial. It guides everything. We generally classify acne into mild, moderate, and severe.
Mild, moderate, severe. Simple enough. How do you tell the difference?
It's mainly based on the types and number of lesions you see. So non-inflammatory acne is usually mild. This is mostly those comedones we talked about, the whiteheads and blackheads.
The early stages.
Right. Maybe up to 10 comedones total, and very few, if any, red bumps, so few papules or pustules. That's generally mild.
Okay.
Then you get into inflammatory acne, which covers moderate to severe. Here, the redness and inflammation are much more obvious. For moderate acne, you'll see more comedones, maybe 10 to 40, but the key is you have a significant number of papules and pustules, those red bumps and pus-filled spots.
So quite a few red spots means it's likely moderate.
Generally, yes. And if you see that pattern, mainly on the jawline in a female patient, you start thinking about possible hormonal links, like PCOS.
Okay. Then moderate to severe.
Moderate to severe acne just means more extensive papules and pustules, often more than 40, and maybe some early nodules starting to appear. This level is definitely more likely to cause scarring.
Scarring is a key indicator then.
Definitely. And severe acne itself is characterized by those large, deep, painful lesions, the nodules or cysts, or that very severe form, acne conglobata. And certainly, if significant scarring is already present, that automatically bumps it into the severe category, even if the active lesions aren't currently at their peak.
So scarring itself means severe. Got it.
Yeah.
Maha's story, starting on the forehead and spreading. That sounds like it progressed, maybe from mild towards moderate or more.
It could well have, yes. That progression is common.
So how is it diagnosed then? Is it complicated? Labs, biopsies?
Actually, diagnosis is usually pretty straightforward. It relies mostly on the patient's history, asking the right questions, and a simple clinical examination, just looking closely at the skin.
No fancy tests needed usually.
Not usually. We generally don't need blood tests or skin biopsies unless something seems unusual. Like if we strongly suspect an underlying hormonal issue like PCOS based on other symptoms, we might do hormone tests. Or if acne isn't responding at all to standard antibiotic treatments, very rarely we might suspect a different kind of bacterial infection like gram-negative folliculitis and do a culture. But for typical acne, history and visual exam are key.
So what kind of questions would a doctor ask? If someone listening is dealing with acne, what should they be thinking about?
Good question. We'd ask about age. Is it typical teen onset or later? Skin type, is it generally oily? Crucially, family history, did parents or siblings have significant acne? For females, we ask about the menstrual cycle. Does acne flare up pre-period? Are cycles regular? Any signs like excess hair growth, called hirsutism, or trouble conceiving? Those point towards potential PCOS.
Okay, cycles and family history. What else?
We'd ask about medications. Are they taking any of those potential triggers we listed, like steroids, certain birth control, lithium? What about cosmetics? Are they using heavy, potentially pore clogging products? And very importantly, the psychosocial impact. How is the acne affecting them? Their mood, self-esteem, social life, school or work attendance.
That emotional side is really important to capture.
It's critical. There's also a super rare, very severe form called acne fulminans, which actually comes with systemic symptoms like fever and joint pain. So we'd screen for that in severe cases, though it's unlikely.
And I guess you need to make sure it is acne.
Exactly. Differential diagnosis. We need to rule out other things that can look similar, like rosacea, that usually has a specific pattern on the central face, the danger triangle, and relaxed comedones. Or perioral dermatitis, which is usually small bumps around the mouth.
Right. Okay, so we've classified it, diagnosed it. Now the big part. Treatment. How do we approach this?
Right, the treatment phase. And what's really interesting is that modern guidelines, like the ones from the American Academy of Dermatology Association, really stress a few core principles that apply across the board, no matter the severity.
Core principles for everyone.
Yeah. Okay, first, combination therapy. Almost always use more than one type of treatment at the same time because acne has those multiple causes, right? So you need to tackle it from different angles.
Makes sense. Hit it from all sides.
Second, no antibiotic monotherapy. Never use just a topical or oral antibiotic on its own, ever. Because it massively increases the risk of developing antibiotic resistance, which is a huge global health problem. Plus, antibiotics work better when combined with other agents that target different parts of the acne process.
Okay, no solo antibiotics. Got it. What else?
Third, topical retinoids are a cornerstone. Think things like adapalene, tretinoin, tazarotene. They help unclog pores, reduce inflammation. They should be part of most treatment plans.
Retinoids. Key players.
Absolutely. Fourth, benzoyl peroxide, or BPO, often called the backbone of acne treatment, usually in 2.5% to 5% strength. It kills C. acnes and has some anti-inflammatory effects, and importantly, bacteria don't seem to develop resistance to it.
So BPO is good for fighting bacteria without resistance issues. What if someone can't use BPO?
Good point. If BPO isn't available or maybe too irritating, azelaic acid or salicylic acid are good alternatives to include. And finally, fifth principle, supportive care. This is huge.
Supportive care, meaning
Using the right complementary products. Non-comedogenic cosmetics and sunscreens, gentle, pH-neutral, or slightly acidic facial cleansers, ideally fragrance-free, not picking or squeezing lesions that just makes inflammation and scarring worse, keeping greasy hair products off the face. It all adds up.
right, those basics really matter. Okay, so applying these principles, let's start with mild acne, like Maha's might have been initially. Mostly comedones, maybe a few red spots. What's the approach?
For mild acne, the approach is usually topical, just creams or gels applied to the skin. A very common and effective first-line combination is a topical retinoid plus benzoyl peroxide, BPO.
The cornerstone plus the backbone.
Exactly. You can often find them combined in a single product, like a gel containing adapalene 0.1% and BPO 2.5%. Applied once a day, usually at bedtime, simple and effective.
Okay, what if BPO isn't tolerated?
Then a great alternative is a topical retinoid plus topical azelaic acid.
So retinoid at night, azelaic acid in the morning.
That's a common way to do it, yes. Retinoids like adapalene or tretinoin go on at night. Tretinoin particularly needs to be applied in the dark as it degrades in light. Adapalene is generally less irritating. Tazarotene is the most potent retinoid, but sometimes harder to find or tolerate.
And azelaic acid.
Azelaic acid, usually a 15% or 20% cream or gel, goes on once or twice a day, often in the morning. Both retinoids and azelaic acid work really well. They're anti-inflammatory, they help break down those comedones, open the pores, we call that comedolitic, and they have some antibacterial effects too.
Sounds like they cover a lot of bases.
They do, and a big plus for azelaic acid is that it's also quite good at fading that post-inflammatory hyperpigmentation, the dark spots left behind.
Oh, that's a useful bonus.
Yeah.
So a mild acne routine might look like
Mm.
gentle cleanser, maybe azelaic acid in the morning, a retinoid or retinoid BPO combo at night, plus a moisturizer and sunscreen.
That's a perfect example of a solid, mild acne routine. Consistency is key.
Okay. Now, what happens when it progresses?
Yeah.
Moderate acne, more of those red papules and pustules, maybe 10 to 40 lesions.
Right. Once you have significant inflammation like that, an antibiotic usually needs to come into play to help get the bacteria and inflammation under control faster.
Antibiotic time. Topical or oral?
It depends. If the moderate acne is pretty much limited to the face, you could try a topical triple therapy first. That would be the topical retinoid plus BPO plus a topical antibiotic.
Adding a third agent, like what antibiotic?
Clindamycin is common and effective. Sometimes dapsone gel is used, which can be particularly helpful for hormonal pattern acne or premenstrual flares in women. Remember, though, never the antibiotic alone, always with the retinoid and Depor BPO.
Got it. Triple therapy for face-only moderate acne. What if it's more widespread, like face, chest, back?
Yeah.
We're starting to scar.
Yeah, if it's more extensive involving the trunk, or if there's any early scarring or maybe some early nodules appearing, then oral antibiotics are generally preferred. A systemic treatment.
Okay, pills. What's that regimen look like?
You'd still use the topicals, definitely keep the topical retinoid at night, and often topical azelaic acid in the morning is a great addition alongside the oral antibiotic.
So retinoid, azelaic acid, plus an oral antibiotic.
Exactly. Common oral antibiotics used include doxycycline, maybe 50 or 100 milligrams once or twice a day. Minocycline is another option, sometimes erythromycin or azithromycin. The course is usually around 2 to 3 months, not indefinitely.
And again, the oral antibiotic is never used alone, right?
Crucial point, never alone. Always combined with a topical retinoid and usually BPO or azelaic acid as well. This fights resistance and just works much better by targeting multiple pathways.
Okay, so for moderate acne with maybe a hormonal pattern on the jawline, treatment might involve a specific cleanser, maybe that dapsone cream in the morning, a retinoid BPO combo at night, a moisturizer, and potentially adding an oral contraceptive pill or maybe spironolactone for the hormonal aspect in women.
That's a very plausible combination for hormonally influenced moderate acne, yes.
Right.
Addressing the underlying hormonal driver can make a big difference.
Right. Now, the really tough stuff. Severe acne, nodules, cysts, maybe acne conglobata, significant scarring. What's the plan then?
For severe acne, you might try a really aggressive version of the moderate regimen first, like a potent topical retinoid, azelaic acid, plus a course of oral antibiotics, maybe for a full 3 months. See if that makes a dent.
Give it a shot.
Give it a solid shot. But often for truly severe nodulocystic acne or acne that's scarring badly or moderate severe acne that just hasn't responded to months of good combination therapy, including oral antibiotics,
Yep.
the go-to treatment, the most potent option we have, is oral isotretinoin.
Isotretinoin, that's the vitamin A derivative.
Yeah.
Known by brand names like Accutane in the past, though there are many generics now.
Exactly. Known often as Netlock or isoacnitin in some readings, comes in various doses, like 10 milligrams, 20 milligrams, 40 milligrams.
Why is it so effective?
Because it's the only single medication that hits all 4 of those root causes we talked about earlier. It dramatically shrinks the sebaceous glands and cuts down sebum production. It helps normalize that faulty skin cell shedding in the follicle. It significantly reduces the amount of C. acnes bacteria on the skin. And it has powerful anti-inflammatory effects.
Wow, tackles everything.
Pretty much. It's a game changer for severe acne. But, and this is a huge but, it comes with very significant considerations and potential side effects. It requires extremely careful management by a dermatologist.
Okay, this sounds like where things get really serious in terms of precautions.
Absolutely. The number one most critical issue. Isotretinoin is a potent teratogen. That means it causes severe birth defects if taken during pregnancy.
Cannot be taken if pregnant, period.
Absolutely not. It's completely contraindicated in pregnancy and also during breastfeeding. The risk of birth defects, things affecting the brain, heart, face, ears, known as fetal retinoid syndrome, is extremely high.
So what does that mean for female patients?
It means incredibly strict pregnancy prevention measures. Females who can become pregnant must use 2 reliable forms of contraception simultaneously, for example, an oral contraceptive pill or an IUD plus a barrier method like condoms. This starts 1 month before treatment begins, continues throughout the entire treatment course, and for 1 full month after stopping the medication.
2 forms, before, during, and after.
Yes. And regular pregnancy tests are mandatory, usually serum and urine tests before starting, another urine test right before the first dose, and typically monthly urine tests during treatment. It's often managed under strict programs like the IPL-DGER program in the U.S. to ensure these measures are followed.
Wow, that's serious commitment. Any other major contraindications or warnings?
Yes. Patients taking isotretinoin must not donate blood during treatment and for 1 month after stopping. Why? Because if that blood were given to a pregnant woman, the isotretinoin could harm her baby.
Makes sense. Drug interactions.
Can't combine it with tetracycline antibiotics like doxycycline or minocycline. That combination increases the risk of a rare but serious side effect involving increased pressure inside the skull, pseudotumor cerebri.
Okay, no doxycycline with isotretinoin. What about monitoring?
Regular blood tests are needed. We check liver function tests, LFTs, and lipid profiles, LP, cholesterol and triglycerides, usually at baseline before starting, maybe again after a month or 2, especially when reaching the peak dose, and then periodically, perhaps monthly or quarterly, depending on the results and dose.
Liver and lipids. And side effects. What do people usually experience?
The most common side effects are related to dryness because it dries up oil production everywhere. Very dry skin, extremely dry lips, cheilitis are almost universal. Good lip balm is essential. Dry eyes, dry nose leading to nosebleeds can happen. Some people experience temporary hair thinning, alopecia.
Dryness everywhere.
Pretty much. Less commonly, it can sometimes trigger an initial worsening of acne or even that rare severe flare called acne fulminans, which might require adding low-dose oral corticosteroids temporarily. Muscle aches and pains can occur.
What about those metabolic changes from the blood tests?
Yes, it can cause increases in triglycerides and cholesterol and sometimes affect blood sugar levels, usually manageable and reversible after stopping treatment, but needs monitoring.
And there have been concerns about mood changes.
Yes, that's an important point of discussion. There have been reports linking isotretinoin to mood changes, depression, and even, very rarely, suicidal thoughts. The evidence for a direct causal link is still debated, and complex severe acne itself can cause depression. However, it's crucial that patients and their families are aware of this potential risk, and doctors monitor mood closely throughout treatment. Any significant mood changes should be reported immediately.
Okay, so it's powerful, effective, but demands real caution and partnership between patient and doctor. How is it typically dosed? Is it a set amount?
It's very personalized. The dose is usually calculated based on the patient's body weight, typically aiming for a daily dose between 0.5 and 1 milligram per kilogram per day, often split into 2 doses with meals to improve absorption.
So a 60-kilogram person might take 30 to 60 milligrams per day.
Exactly. But you usually don't start at the full dose. Doctors often start low, maybe zero point 0.1 milligram a day or just 10 milligrams daily, and gradually increase the dose over several weeks or months. This titration helps the body adjust and can minimize some side effects, including the initial flare. Sometimes, as mentioned, a short course of low-dose prednisone or prednisolone is given right at the start alongside the low-dose isotretinoin, specifically to prevent a severe inflammatory flare-up.
Start low, go slow. Makes sense. How long does treatment last?
The goal isn't just to clear the acne, but to reach a specific total cumulative dose over the entire course of treatment, again based on body weight. Usually the target is between 120 to 150 milligrams per kilogram total. Reaching this cumulative dose seems to reduce the chance of the acne coming back later.
Ah, so it's about the total amount taken over time.
Exactly. Depending on the daily dose, reaching that target cumulative dose often takes about 6 to 8 months, sometimes a bit longer. Treatment might be stopped earlier if the person has been completely clear of acne for, say, 8 weeks, and the doctor feels enough drug has been accumulated.
Okay. So for severe nodular cystic acne, the path might be try aggressive moderate therapy first. But if that fails or it's very severe from the start, move to oral isotretinoin, start low, gradually increase, maybe use initial steroids, monitor closely for side effects in pregnancy, aim for that cumulative dose over 6 to 8 months.
That's a very good summary of the typical approach for severe acne requiring isotretinoin.
Phew. That's a lot to consider with isotretinoin. It really underscores why that supportive care you mentioned earlier must be so important, regardless of the treatment intensity.
Absolutely critical. You can't just rely on the active medication.
So what does this supportive care mean for you, the listener, in practical terms? Managing acne isn't just about the prescription creams or pills. It's really about creating a skin-friendly environment throughout the process.
Couldn't agree more.
The power of this supportive care is huge. Let's talk moisturizers. Since so many treatments, especially retinoids, BPO, isoleic acid, and definitely isotretinoin cause dryness, using a good moisturizer is non-negotiable.
Essential. Especially with isotretinoin, you need quite rich emollients sometimes.
Right. Look for things labeled non-comedogenic so they won't clog pores, and ideally fragrance-free to minimize irritation. Ingredients like ceramides, hyaluronic acid, glycerin, panthenol can be helpful. Brands like CeraVe, Cetaphil, or specific ones like panthenol creams, bepanthen, ruchipanthenol, melanthanol gel, no-lover, depending on what's available, and suits your skin.
Find one you like and use it consistently, often multiple times a day if needed.
Then sunscreen. Also vital. Many acne meds make your skin much more sensitive to sunlight, photosensitive.
Big time. Retinoids, doxycycline, isotretinoin, they all increase sunburn risk.
So daily use of a broad-spectrum sunscreen, SPF 30 or higher, is a must. Rain or shine, indoors or out, as UV rays come through windows. Again, look for non-comedogenic and maybe fragrance-free if you're sensitive. Brands like La Roche-Posay and Thelios, Beesline, Dermactive, CeraVe, Sunlove, lots of good options out there.
And reapply if you're outdoors for extended periods.
Good point. And lastly, facial cleansers. We touched on this, gentle is key. You want something pH neutral or slightly acidic, definitely fragrance-free. You're not trying to strip the skin, just gently cleanse it.
Exactly. Harsh cleansers just cause more irritation and dryness, making it harder to tolerate the treatments.
So examples might include brands like Cetaphil Gentle Cleanser, CeraVe Hydrating Cleanser, or maybe some mentioned earlier like Cynobar, Clearcell, Tetrahydro, Nanotret. Some of these might contain salicylic acid, which can be helpful but also potentially drying. Demicap. The key is gentle and non-irritating for your skin while on treatment.
Find one that leaves your skin feeling clean but comfortable, not tight or stripped.
So, moisturizer, sunscreen, gentle cleanser, the trifecta of supportive care. Now briefly, are there other therapies sometimes used? Add-ons?
Yeah, there are a few other tools in the toolbox for specific situations. There are some newer topical androgen inhibitors, like clascoterone, that target hormone effects directly in the skin, though availability varies. Newer topical retinoids like piferritin are also emerging.
Great.
For females with hormonal acne, or PCOS, as we mentioned, combined oral contraceptives, pills like Yasmin, Yaz, Diane-35, can be very effective by regulating androgen levels.
Birth control pills as acne treatment.
Yes, specific types are FDA approved for acne. Also for females, particularly with resistant hormonal acne, the oral medication spironolactone can be used. It blocks androgen receptors, but it requires monitoring of potassium levels and blood pressure and can't be used in pregnancy.
So hormonal options for women. Anything else?
For those really big, painful, isolated cysts or nodules that pop up, a dermatologist can sometimes inject a tiny amount of corticosteroid directly into the lesion, intralesional injection. It helps shrink it down and reduce inflammation very quickly. Good for a quick fix for a particularly bothersome spot, but not a primary overall treatment.
Like an emergency intervention for a really bad one.
Sort of, yeah. Helps manage those big, painful ones symptomatically.
Okay. Wow, we've covered a lot of ground here.
We really have. We've journeyed from that tiny pilospacious unit, explored that complex storm of hormones, oil, blocked pores, bacteria, and inflammation that causes acne. We've seen how classifying acne severity is key to guiding treatment from those topical creams and gels for mild cases, adding in antibiotics for moderate, right up to the heavy hitter, oral isotretinoin for severe or stubborn cases.
And all along, emphasizing that crucial supportive care, the moisturizers, the sunscreens, the gentle cleansing. Maha's story, starting localized and then spreading, really highlights how acne isn't static, it can evolve, and treatment needs to adapt.
Exactly, it's a dynamic condition.
So, reflecting on all this, it really raises an interesting question for the future, doesn't it? As we learn more and more about the skin microbiome, that whole ecosystem of microbes living on our skin.
A fascinating area of research.
Right. How might future acne treatments change? Could we move beyond just, broadly targeting bacteria with antibiotics towards more sophisticated ways to modulate or rebalance that specific skin microbiome, maybe more targeted, personalized approaches?
That's the hope, isn't it? More precision, fewer side effects, perhaps by promoting beneficial bacteria or targeting the harmful actions of C. acnes more specifically. It's definitely where a lot of research is heading. What new insights did you gain today? And what questions does this deep dive spark for you about your own skin or maybe the future of dermatology?